Welcome to the course Introductory Neuroscience and Neuroinstrumentation. We are in the week 10. So for the final 3 weeks, we have decided to touching up on some of this topic which are currently in the neuroscience and neuroinstrumentation or neurocomputation research. So far you have been taught about different systems to acquire EEG, how different kind of cognitive experiment performed, how different types of microfabrication process works. Building upon this basic fundamentals, here we'll see how we can leverage those fundamental process to convert it into clinical application. So basically, the main agenda behind taking this recent advances in neuroscience and neuroinstrumentation module is to let everyone know that how these concepts can be translated into clinical or neurological applications. So for today's this module, we will be covering epilepsy classification using EEG data. So for epilepsy patient or epileptic subject, EEG is considered as a gold standard. Of course, it depends on the progression of the disease and what is the actual status of the patient. But this is the normal clinical practice that if somebody have a seizure, that person should undergo a video EEG or a long-term EEG test with respect to specific triggers, and they will measure the brain waves recorded as per system. There are many protocols, and so they'll observe or analyze. Basically, a neurophysiologist or experienced neurologist will particularly analyze the trace, and finally they will provide an impression that this person is epileptic, and of course they will provide medication and sketch the further way of treatment. So this is the normal procedure when it comes to dealing with a person with epilepsy. So why epilepsy classification using EEG data is required? So in India, there are very few registered neurophysiologists, and compared to that, the patient who is suffering from epilepsy are huge in number. So if statistically it will talk, it's around thousands of patients per one neurologist. So practically it's impossible for a neurologist to check each and every patient's data and come up with an impression. So this is an ongoing research in the field of neuroscience that your EEG can be recorded. For that, you don't require a neurophysiologist. There can be a technician who can record your EEG, and further that EEG data can be fed to some algorithm or some logic device which can tell you that finally the outcome of the patient, or this person has epilepsy and this person has this kind of epilepsy. So this is one of the ongoing research in the field of epilepsy classification. So let's first see what epilepsy is, and I'll provide you a basic introduction about the disease epilepsy. So yeah, epilepsy is a chronic neurological disorder of repeated seizure. Now the seizure term is frequently used in the literature of epilepsy. It means that your body will become rigid, there will be a contraction of your muscles, and basically a subject or epileptic subject will not have a total control of his his movement, and further it can result in very adverse consequences. So this is basically the prevalence, how prominent the disease has spread so far. So more than 50 million people are already affected in epilepsy. And this is data which has been taken almost a few years back. So, and if I talk about India, it's around 10 million people who are already affected in epilepsy. Worst thing is that about 1 in 3 has a refractory epilepsy. So, refractory epilepsy is that there are to combat epilepsy, to eliminate epilepsy, you have anti-epileptic drugs. So ideally, the assumption is when epilepsy is found, you will give anti-epileptic drug to a particular patient, and that patient should be survived. But there are a kind of epilepsy which won't respond, or which won't get recovered by a specific known anti-epileptic drugs. So these are the epilepsy known as refractory epilepsy, who does not respond to anti-epileptic drugs. So if I talk about refractory epilepsy, then the rates are 4 to 7 times higher than what is being observed in normal epilepsy. Further, the key point, or the idea, or the motivation is that most of them can live seizure-free life if diagnosed and treated at a proper time. So, of course, there is a treatment gap because not all patients can get the advice of doctors. I should say timely advice of doctors exactly during some onset or after some episode. It should be detected or observed by doctor. So this basically, there is a significant observable treatment gap exists in terms of epilepsy. And suppose it's, if not detected, what can happen to a patient? A question might arise. So there are several very adverse consequences are there. So of course, epilepsy can be fatal. So there are different type of epilepsies. In some of the epilepsy, patient will not remain in consciousness. Like currently I'm talking with you, within 10 seconds I'll be totally blank. I'll not say anything. I don't know what is going on around me. After 10 seconds, suddenly I will be in complete consciousness. So this loss of consciousness is known as absence seizure, and this becomes very dangerous when you are driving a vehicle. So this kind of epilepsy can easily result in fatal consequences. Further, as I mentioned, you don't have a control of your body, so it might happen that you may fall down. So I have seen patients of epilepsy from very closely. So I can say that they might have fallen down from different in different scenarios. Like I have one I know one of the epileptic patient who has fallen down from a motorbike like this. Like his head is, he has fallen down to the backside of the bike, and his head was fallen stuck on the road. So basically, the idea of providing all these examples is that a person will not have its own control, its own consciousness. As a result of that, there are chances of very excessive body injury. If it hurts on some of the body parts, it can be recovered considering the degree of injury. But if something happened to your brain, and if some of the cortex or some of the main part tissues of your brain will get damaged, it can affect your sensory system. It might happen that after falling down, your head is stuck on to something in such a way that you might lose your vision, or you might lose your memory. So again, a very difficult scenario if not treated by time. You might face, as I mentioned, some of the physiological dysfunction. You won't be able to sense, or you won't be able to hear something based on your damage due to epilepsy. Further, if I talk about the social aspect of epilepsy disease, it has been reported the epileptic person will soon lost the interest in their spouses. So there are marriage rates, and like epilepsy has affected the marriage, as well as that person will not find himself. He won't get attracted towards the social crowd and all. The person will start remaining uh, separated from the crowd, and so in general, it's a very difficult situation to handle if not detected on time. So, how do we detect epilepsy? In what? How do a neurophysiologist or neurophysician, neurologist approach for any epileptic patient? So, I already mentioned that in the preliminary cases or at initial level, EEG would be advised, and then the traces or final data stream would be observed, and impression would be provided to the subject, epileptic subject or affected subject. But if I talk in detail, so epilepsy can be described by two things. One is a seizure, other one is syndrome. Okay. So in medical science, syndrome plays a very vital role. Basically, uh, syndrome or symptoms will provide you the details, the history, how the disease, irrespective of epilepsy, for any disease, symptoms or features or syndrome plays a major role in medical science. When a subject will provide an information, the patient history is a vital thing for any disease, especially for epilepsy. What are the things they will measure is that when the episode happened, when the seizure happened, what are the consequences? Next time when the thing is happened, what were the consequences? So, and one more thing, for specific set of human beings, there are different kind of seizures. Like some of the seizures can only be observed in child, some of the seizures can observed in aged person, like that. So all this thing will be taken into consideration for syndrome. Whereas if I talk about a seizure, seizure is more of a technical term. It is basically an abnormal discharge of electrode from your brain. So seizures you can observe, verify, validate using an EEG. Like one more thing I would like to clarify here, very important, is when a person will be having experiencing a seizure, it's very difficult to record EEG, because for EEG recording you are placing electrodes on the head of the subject, right? Now when you place the electrode on head and seizure comes, the person will surely have muscle contraction, stiffness, you will feel stiffening and all. So it's very difficult for a person to remain as it is. And when the person will move, if I'm telling you, that person will move like anything, that person will feel like jerks and all. So what will happen is that there will be a lot of muscle movements, or that function results in EMG. Now EMG is basically a muscle biopotential which has a far higher value than EEG. So there are very very high chances that your biopotential EEG will get eliminated in between this EMG. Basically, the prominent waveform which you can see outside would be the EMG, and which is not able. The EEG would be there, but in a very small term, very difficult to extract EEG from EMG when a person is throwing a seizure. So, why in that case, why EEG is advisable? Because anyway, when seizure happen, you won't be able to get the EEG which you want. But there have been evidence in the literature. It has been known that in between two episodes of your epilepsy, your EEG, your biopotential will provide some of the information about the epilepsy and type of epilepsy. So basically, you had a seizure, you cured, you had some injury, injury and all would have been recovered. But before your next episode, that can be after 1 month, after 1 year, after 2 years, after 5 years, or if you have been provided a correct proper anti-epileptic drug, it won't happen as well. So before the second episode, your EEG would have been taken. It would have had a footprint. That your EEG will show that a person will have some form of problem, or the person will have specific, it can be region specific as well, like person's occipital lobe or right side of the occipital lobe has some activity, there is some issue there. Person's frontal lobe has some issue, or it might be that your entire head had some issue. So based on the progression of your disease, or based on where you are observing uh, abnormal discharge, okay, this excessive neuronal discharge, it can be identified that which kind of epilepsy you have. Okay, so we'll quickly run through this details. The seizure is basically electrical storm, which I already mentioned. It will be a discharge of your a discharge observed from the scalp electrode. It can take a control of brain and may lead to dangerous fatal consequences, noted down here. Further, yeah, pattern of seizure is important parameter for epilepsy classification. Which kind of as I mentioned, from which region it is and how prominent and all. So and patient's history, I already mentioned, that plays a vital role. And yeah, one more important thing is that there are, as I mentioned, two types of epilepsy. One is it can be across your brain, where one is in the particular part of your brain. So it's named as generalized epilepsy and focal epilepsy. Focal epilepsy means your epilepsy focus would be at particular region of your brain. It is limited to a particular region of your brain, whereas generalized would be everywhere. Generalized epilepsy mostly occur due to some imbalance of your neuronal. It can be genetic as well, whereas focal epilepsy mainly happens because of the some brain injury or some, basically. So that's why it can occur anywhere in your head injury. In head injury can occur any place, so might result in some epilepsy or focal epilepsy. That's why if your brother or your relative would be having a generalized seizure, there are high chances of direct brother or sister would have the same, because it's can be due to the genetic properties of a subject. So yeah, talking in the nutshell about the slide, epilepsy can be characterized by two things. One is seizure and one is syndrome. Doctor, when you approach a doctor, they'll ask for patient history, everything. Using that, they will decide the syndrome, as well as they will obtain the EEG, ask you to go through EEG test. They will check your data stream, and they will tell that, okay, you have this kind of epilepsy. So further, we will see specifically that why epilepsy classification is required. So there are different kind of, as I mentioned, focal, generalized. I already told about absence seizure. So the different type of epilepsy, accordingly, there is a different type of medication. And if at all you misclassify a subject, or if you give a generalized epilepsy patient medication which should be given for focal, there are high chances of the person who has generalized seizure will have more issues. Or in the other way, a person's only one particular part is damaged or has issue. Focal patients, if you give generalized anti-epileptic drug, it might happen that person will start observing a generalized seizure. Okay, so type-based medication is very important, and this type-based medication has the most influence in recovery rate, or in coming out of epilepsy, which is very difficult. So it has the most influence on the therapy of epilepsy recovery. So further, how do we differentiate a normal subject from epilepsy? Because like I mentioned, there will be a abnormal discharge, there will be a different form of wave, but how can we make a difference from a normal EEG compared to the EEG provided by when it is taken from epileptic subject? So this is a very nice illustrative diagram. If you can see that here, if you see, this is a normal EEG. So nice baseline is going on, there is nothing, no much movement. Of course, this is illustration. Whereas if you talk about here, okay, here there is some onset. This yellow color structure shape is just showing that this is the onset of your seizure. So at that time you can clearly see that there is a lot of movement. So this is at a time of seizure. If you take interictal, like in between two seizure, if you take recording, then also you will find a clear difference in the patterns. So now the idea is how we can screen, or out of you, as I mentioned, there are many thousands of patients per one neurologist. So which 100 patients the neurologist should see the first? So that is being decided when you have one screening algorithm for epilepsy. So what is the idea, or how you can screen a particular patient for epilepsy is you will just observe this spike waveforms here. There are some of the patterns in the waveform which is a characteristic biomarker or a pattern which is a signature for a different type of epilepsy. So what you can see here is by just a normal vision, like I can see here with a naked eye, I can clearly make out a difference between normal and generalized seizure EEG patterns. So same thing, you can model, you can perform some algorithmic check, you can take a benefit, take a use of mathematical algorithm like fast Fourier transform, time frequency analysis, and further to come to a conclusion that okay, this person have this kind of epilepsy. This is in between normal EEG and epileptic EEG. Now, how do we differentiate in between two epileptic subjects, whether the subject has generalized epilepsy or focal epilepsy or absence epilepsy, or there is one more type here, it's written focal to secondary generalized. So I have already told about focal generalized. Absence, the different type of epilepsy, which I have mentioned when I was going through the consequences or fatal consequences of epilepsy. So here, focal to secondary generalized epilepsy is nothing but we can consider it as the intermediate stage in between focal to generalized. Okay, so in general, all focal epileptic cases are generalized, but with very small degree of generalization. So that is the neurophysiological basis behind this, and we won't go into the detail because idea here to let you know about what are the difference in EEG, or if you can see the pattern by yourself, you would be able to at least detect that okay, this person has epilepsy, or this person has this kind of epilepsy. Okay, so these are the four major types. Further, there is a International League Against Epilepsy. They have come up with their own classification in 2017. So I would like all of you to just have a look at that. After understanding the details so far, you would be able to understand this thing, that thing very clearly, that they have basically three sections: focal, generalized, and unknown onset. Based on onset, they have divided into three parts. It's a good read. You can go through it. International League of Epilepsy. Now coming back here, that this is been useful to differentiate between normal and EEG. How do we delineate between partial seizure and generalized seizure, or focal seizure and generalized seizure? So it's why I included this thing in the presentation here is a very nice illustration of how you can get the information or how you can differentiate between generalized and focal seizure. So if you see here, only two of the channel is observing an activity, whereas here entire all four channels or four electrodes are observing irregularities. So basically it is starting from here and spreading everywhere. That is what this particular image, or this sky blue colored circles wants to show. Whereas here, if you can see here, this is a small circle. So this is focused to a particular area. That's why it's basically a focal seizure. So further, we will see how EEG is recorded, and what basically specifically people do for EEG recording or for epilepsy screening, or yeah. So further, this is the experimental protocol that it is recorded generally from 30 to 45 minutes. And what do they do for this 30 to 45 minutes time period? So first and foremost thing, if you go for any epilepsy EEG test, they will ask you to come sleep deprived. So what they will ask you is, you complete your 4 to 5 hours of sleep and come back, come for test. Why that is required is because sleep deprivation is one of the kindling factor for epilepsy. If your sleep is not finished, there are very high chances that you will show some epileptic behavior, or your brain will discharge some of the biopotentials in higher rate compared to a person who has a sound sleep. Anyway, one more thing for any in general epileptic patient is that they are advised to maintain three things very properly: their food intake timings, the sleep, and the medication. Very important. All three things should be and must be followed in as regular manner as possible in order to eliminate the further chances of episode. Anyway, sleep deprivation is one of the main cause of epilepsy. So subject is being asked to come sleep deprived, so that in between they can when they record EEG, they will get this kind of signature, using which they can identify that this person has this type of epilepsy. What are the different experiment or different stimuli they will provide? In the previous modules of mine, I have already covered auditory and visual stimuli. It is somewhat different case here, but on the whole it remains the same. So first subject will come, they'll place an electrode, and they will check impedance check. Again, I have covered it into experimental protocol that will check everything is properly working fine and all. So electrode placement, after electrode placement, they will check the impedance, they'll match the impedance if the impedance is fine. Different system have different input impedance, so it should be matched with your skin in order to obtain the desired response. Further, they will be subject will be presented to a photic stimulation. So photic stimulation, what they will do is at 1 hertz, 2 hertz, 3 hertz, 5 hertz, 6 hertz, they'll increase the frequency and they'll keep glowing particular light. They'll keep throwing the light to a subject. It may happen sometimes due to this kind of photic stimulation, your brain will throw some form of abnormal discharge. Basically, your some irregularity in your EEG. So all this thing, again, they will ask you to hyperventilate. Hyperventilation is also one of the protocol that has been used in many EEG related studies. And this all things, like all the different kind of stimuli and all thing, will happen for 10-15 minutes. After that, they will ask a subject to sleep, try to sleep. Subject, most of the cases, as subject has come sleep deprived, subject will sleep properly. And when the subject would be resting at that time, again there are chances of observing abnormal activities. So this thing is basically what will happen when a subject will go for EEG test for epilepsy screening. Again, in the course, during the course 10-20 system, I have also covered once, and this is basically, I'll quickly revise because there are many questions about that, so I'll just quickly revise this thing. 10-20 system is nothing but an international standard to record EEG. Now why 10-20 system is required? Simply because my head size and your head size would be different. So you cannot simply say that, okay, above your nose or nasal, you put somewhere after 5 centimeter, and from your right ear 6 centimeter. For me, that point would be 1 point. For you, that would be some other point. So from your nasal to inion, nasal is nothing but this point. This point is nasal, whereas inion, when I just scroll my hand or I move my hand towards the backside of my head, there will be a trend, there will be a change which you can measure. So that is at the near to your neck, that is your nasal, that would be your inion. This is your nasal. From nasal to inion, the entire part is divided into different parts of 10, 20, 20, 20, 20, 10. Same goes for left ear to right ear, divided into 5 parts of 10, 20, 20, 20, 10. And this is your final electrode position. you can note that all the left side electrodes having odd number, all the right side electrodes having even number, whereas this all the electrodes with Z represent the midline. So this is basically a 1020 system. Whenever you go for EEG recording, they will be having a cap supporting 1020 system. Also, you should know that which are the lobes. So frontal, central, temporal, parietal, occipital. So there are some of the epilepsy which is specific to a particular lobe. So if I talk about in US there are very many cases of TLE, that's called temporal lobe epilepsy. So mostly the seizure would be focused around T3, T5 or T4, T6. So important to know all the nomenclature and why people are using 1020 system. Again, in 1020 system, there are different kind of way to record your data. I already mentioned before about the montage. Same thing applies here as well. Monopolar as well as bipolar. And this bipolar EEG waveform is known as a double banana because F1 minus F3, F3 C3, C3 P3, P3 O1, like that. This would be your first banana and this would be the another banana. So it is known as a double banana montage. And this is how particular recording, this is just an illustration taken from some content on internet, but yeah, the idea is to let you people know that this is how basically EEG would be recorded inside the clinical environment. So I think experimental protocols and things are now clear. This is how EEG is being recorded. Further, I will tell you how we can extract the information, or looking at EEG, how you can say that okay, this person has a problem and this person does not have a problem, how to see the abnormality, how to quantify the abnormality, and how do you see that. So this is basically a signature to conclude that if a particular person is epileptic or not. So what do we measure or what do we see in particular EEG waveform is this is the main component. If you can see the A part is nothing but your spike. B part is your sharp. C part is spike and wave. So a small spike is shown along with the wave. D part is sharp and slow wave. E part is slow spike and wave. Here it's a poly spike, and the same spike is occurring multiple period of times followed by waves. Again, multiple sharp and slow wave, poly spike, multiple sharp combination. Now what is the use of defining this many number of patterns? So basically any EEG, any human EEG for epilepsy can be mapped or can be transformed into three basic shapes, that is spike, sharp and wave. So those who know machine learning or artificial intelligence, or those who are in the field of mathematics would be easily able to relate with that your entire EEG waveform can be mapped into three variables, three patterns, that is spike, sharp and wave. Those who are not aware into the detail of machine learning or feature extraction, in simpler words, what I wanted to say is that all the recordings of EEG is a combination of spike, sharp and spike and wave. So how do you delineate between spike, sharp and spike and wave, or how do you say that okay, this particular waveform is sharp? So if you see A and B, it looks almost similar. The only thing is the duration, the change in time makes it this particular waveform or this particular pattern is sharp and spike, and this is sharp. So there are in literature, there are durations of spike and sharp defined. Additionally, one very important point is spike and sharp, you can clearly see it will stand out from your baseline. Baseline is nothing but your normal ongoing EEG without much activity, but compared to that, there will be change. So abnormality you can easily catch. Basically, your normal human ongoing EEG, it's around within baseline is within plus or minus 10 microvolts. So when you target spike or something, you can take 3-4 times more amplitude, and then you can check for the duration, as well as there is a frequency is also defined. What should be the what are the frequency component beneath it? So for that, a lot of Fourier analysis, frequency analysis is required, and further you can perform some another domain analysis like wavelet analysis and all, in order to come up with a better feature, type specific feature, which will tell you that okay, this particular pattern is spike, this particular pattern is sharp, and so on. So idea behind letting all of you know these different patterns is just that your input EEG, human EEG waveform, you convert it into a number of spike, sharp, and wave. You will be having features ready for your further epilepsy classification. So I hope this is clear. So what I am trying to say is, this is one of the actual human EEG sample recorded. Further, it should be pre-processed. So this is a raw signal recorded in Nicola EEG system. It should be pre-processed. Why? Because there are so many that normal recorded human EEG will have so many artifacts. So what is artifacts or noise? Anything apart from your biopotential coming out of your head. In other words, anything except information is your noise. So all this noise, this can be due to this can be physiological as well as this can be non-physiological. So it can be due to some issue inside your body, or it can be due to some environmental factor, like if EEG is being recorded in India, then there are 50 hertz frequency, whereas Pavlan artifact, which has been observed in US, will have 60 hertz frequency. That's one artifact. Whereas if a person is moving, if a person eye will be blinking, if you move your eye, then also there will be an artifact which should be rectified. Further, it has been reported in some of the subject that there are some thing called Ecg artifact. Your heart pumps inside your body, so there is the effect of your Ecg on EEG, and there are literature available to remove your heart's like not exactly ECG, but reflection of your ECG on EEG. So all this thing will come into the picture when you talk about the pre-processing of your ECG. But once you pre-process it, you have to check it for different you can divide this entire trace into particular different segment of time. After dividing your data stream into different number of sections, you can check a frequency response. Also, you can check the amplitude, whether it is much higher than baseline or not, and check for particular segment what is your frequency response, compare it with the frequency response of spike, and you can say that okay, this particular thing is spike. So similarly here you can see out of this raw data, after pre-processing it, you will find this much spike compared to your pre-processed data. So this is just one example which I have provided to extract a spike, or how you can get the spike. Similarly, you can perform the analysis for sharp and wave and come to a conclusion that in your input data EEG file, you have this many numbers of spike, then you have this many number of sharp, and this many number of waves. Additionally, important thing is that which particular site, which electrode is having this kind of waves. One very good thing about EEG is EEG has excellent temporal resolution. So if something happens in your brain, it will get recorded almost at the same time, whereas it won't have that much higher spatial resolution. Suppose you have a brain tumor or head injury, then EEG would not be that much useful. In that case, you should go for fMRI or some intracranial or an invasive EEG, when your skull will be open and electrodes will be placed on the affected side. So yeah, coming back to the epilepsy classification, like I have done for spike, you can do it for sharp and waves, and not only for one channel, for multiple channels, and finally you can give some impression that this channel is having some activity, and further There are some of the one point here I would like to mention is that some of the epilepsy will have a specific combinations of pattern as a signature. Like for absence seizure, there is a pattern of spike and wave. So spike and wave will keep on repeating. So then you have to extract spike, you have to extract wave, and you have to check for the incident where spike is followed by wave. So basically I hope you people have now idea that how you can trace or how you can extract different kind of patterns from your input EEG signal to conclude the type of epilepsy. So I'll show you what can be the simplified flow for epilepsy classification. Motivation behind showing this is to let everyone know that what should be the flow further. There is a lot of mathematics and frequency analysis involved if you want to play with the data, or if you want to make a screening tool. It would be useful, and a lot of literature is available, so you can go through some of the epilepsy classification literature. Main objective is to automate the process to reduce the load for clinician and make a screening tool. So this is basically a final classifier which a person should block diagram of the classifier. From EEG data, it will be pre-processed, and it will be given after extracting some of the feature. It will be conveyed to a classifier. That classifier will also have an input from your experimental protocol, like during which period of time you have been provided photic stimulation, during which period of time the patient was hyperventilated. Now at some point of time the patient will move. So there is one person who sits in observe the entire process, or observe the subject during the entire course of test, that whether a person is moving or not. So all these inputs in actual EEG data, this has been noted down, that a person moves at 10 minutes 5 seconds to 10 minutes 15 seconds. So basically when you see the EEG, you can discard those period of time because there will be a movement artifact. So all these things are the inputs from experimental protocol. Further, if a person additionally with this, all this detail written by a person, in some of the hospitals or units, they will provide a video recordings. So there will be a one constant camera on the face of the person, or it will cover the it will cover some of his body, so some part of the body. So then in a way they will observe the moment or something. So again they can it is for better interpretation of your EEG data. And last but not the least, syndrome. So syndrome, if you get features, if you say symptoms, so all this thing. So once all these things are finalized and provided as an input, here the epilepsy classifier can tell you that which kind of whether the person is having focal, whether the person is having generalized seizure, or the person is having absence seizure, etc. Accordingly, medication should be provided. So main objective behind this module is to glance through the algorithm, or glance through the idea that how you can automate the process of epilepsy classifier. Currently, instead of this epilepsy classifier, one neurologist or neurophysiologist will sit, observe, and provide his impression. So can we automate this thing? Can we come up with a better idea? Can we come up with a tool? So we have a tool to record EEG data. So can't we come up with a computational unit which can automatically say that okay, this person has this type of epilepsy, or at least reduce the load of clinician. So I hope this lecture would have given you some idea about automation regarding epilepsy classification. I will meet you in the next week with one more exciting topic. So far what we have seen is non-invasive EEG, when scalp biopotentials or scalp response is recorded. Further, if we open the skull and go inside, will it be more beneficial, or should we do that, or is there what are the significant advantages of invasive EEG techniques all this thing and a couple of more applications which has been currently is used or currently uh, in research field. It's like ongoing research. All this thing I will discuss in the next week in one of the module. Till then, all of you take care. Bye.